So it's an honor for me to present Dr. Friederike Erdmann, who is an internationally trained cancer epidemiologist. She's the head of Division of Childhood Cancer Epidemiology and the German Childhood Cancer Registry at the Institute of Medical Biostatistics, Epidemiology and Informatics at the University Medical Center of the Johannes Gutenberg University, Mainz, Germany. She's also a guest scientist at the Department of Prevention Evaluation of the Leibniz Institute for Prevention Research and Epidemiology in Bremen, Germany, and visiting scientist in the Environmental and Lifestyle Epidemiology branch at the International Agency for Research of Cancer, the World Health Organization Specialized Cancer Research Agency located in Lyon, France. She will talk to us about social inequalities in childhood cancer. And before I give her the speech, I would like to express a great thank to her because she's also helping Cyprus to understand better the childhood cancer problem in our country. And we are very grateful to her for that.
Thank you so much. Thank you very much for the kind introduction. And also thank you for the great collaboration. He's very dedicated and it's a lot of fun working with him. And also thank you so much to the organizers for having me. It's a great pleasure being here. It's my first time. Thank you so much on Cyprus. And yeah, thank you so much for giving me the possibility to talk about social inequalities in childhood cancer. As you just heard, I'm a cancer epidemiologist and I also have a background in public health, so that topic really matters to me. You have heard now already a lot about childhood cancer, and now I'm looking at it a little bit from a different angle. So inequalities in health, according to social conditions, are, or I regard them as unnecessary and unjust, and there is a large body of evidence on inequalities in adult cancer, observable throughout societies and across societies, different countries with different level of socioeconomic development. And but actually social inequalities influences health at all matters, at all age, and including childhood, and childhood cancer is one of the most rare diseases in childhood, so I think it's very important to to consider this. So does this work? Yeah, good. So although it's important to keep the entire course of childhood cancer patient in mind, I will focus with my talk today especially on inequalities in survival and psychosocial and socioeconomic consequences for affected patients and their families, and also after surviving the disease, since I see here the greatest potential for any action or a strategy to improve the situation actually make a difference. As we can see here very nicely with a graph actually showing survival curves from the UK, and some colleagues in the audience actually know much better than I do. Treatment of childhood cancer is a true success story of modern medicine, and over the past decades, advances in diagnostic procedures, risk grouping, and treatment have led to substantial improvements in survival. Here we can see the 5-year survival from childhood cancer increasing from 30% in the 60s to over 80% nowadays. However, not all children benefit equally from these recent developments, and there are actually substantial survival differences seen between countries and within countries. Here we see survival estimates for European region. That's the Eurocare 5 project, and it's from the diagnostic periods 2005 to 2007, so it's a little bit outdated survival estimates, but it's still good enough to make my point. And survival estimates are not available for all countries, so that's why I thought this is good to present here anyway. And what you can see here, I just marked it in green and compared it to Eastern Europe in red, that you can really see the differences even within Europe between Northern, Central, Southern Europe compared to Eastern Europe. And I just marked it here for all childhood cancer, but also particular seen for AML and also ALL. Yeah. And here, since survival data is so limited, particular for countries actually with a lower position in terms of socioeconomic development, which is particularly interesting to look at, I'm showing here mortality rates, which give kind of an could be understood as a proxy for survival estimates. And I also wanted to point out, because it's very impressive that mortality rates are actually so low. here, Cyprus, and also you heard it already. My home country is Germany. That you can see also Germany is having very low mortality rates. In comparison, we see the same pattern here as before. When you look at the higher mortality rates, that they are actually coming from Eastern European countries with a lower socioeconomic development. And what we can also see that actually the social differences for childhood cancer is bigger than for adult cancer. And this is, I found particular concerning. But moving to survival inequalities within countries. So there is evidence that accumulating that not only clinical factors, but also social and socioeconomic factors are associated with childhood cancer survival. And that is even in European countries where equal access to healthcare services, irrespective of social background, is assumed. So there is evidence from countries like Norway, Denmark, Sweden, Finland, Greece, Germany, Switzerland. So I found that, particularly as a PhD student, I found it very concerning. I was doing my PhD work partly on that. And so there is lower survival demonstrated for children of families with lower parental education, with lower income, for single parents with poor living conditions, or children with having more siblings or of higher birth order. However, while the underlying mechanism and pathways of survival inequalities in cancer are actually well studied and also quite good understood for adults, this doesn't hold true for childhood cancer. And although it's actually of significant public health relevance, because understanding the mechanism would be the starting point for any action or strategy to aim to reduce those inequality, we really don't know for childhood cancer why this is actually, why we see these inequalities. So I found it very interesting to show you this year. Colleagues from the UK have studied survival from acute lymphoblastic leukemia by SALiCCS. They used an area-based deprivation score. And they've observed very interesting findings. As a background information, treatment of lymphoblastic leukemia usually lasts several years, and poor adherence to oral maintenance therapy is associated with negative impact on the outcome. And children get typically discharged from hospital after about 8 to 9 months. And then the parents are responsible for complying with the recommendation for continuation of the therapy, and that includes daily drug intake and outpatients appointments and so on. And what the colleagues from the UK found was that survival differences emerged basically by the time where the management of the treatment or the administration of the treatment moves from hospital to home. So they concluded, or they have hypothesized, that these social differences may be related to the treatment adherence of the family and of the parents and caregivers. However, I found it then interesting, of course, to look at those patterns also in other countries. And since I have worked previously in the Nordic countries, so I show you a lot of actually findings now from the Nordic countries. So I looked at that also in Denmark, and colleagues of mine looked at that also in Sweden. And it's not seen neither in Sweden nor in Denmark. Also in Finland, it doesn't really support the hypothesis. So we do think that there must be also other mechanisms in play. In particular, when you think about the hypothesis from the colleagues in the UK concerning ALL, that would imply that childhood cancer types which are mainly treated in hospital, that you wouldn't see as strong social inequalities in survival. But this is actually also not what we see. So we do think there are other mechanisms in play, and together with some colleagues from Denmark, I had the idea that maybe some social groups have difficulties navigating through the healthcare system. And what we actually saw is that that families with lower socioeconomic position, defined by different measurements, have more frequently and more contacts before the actual diagnosis of childhood cancer, meaning it takes more contacts with the healthcare system before the child gets diagnosed with cancer. And that can, of course, end up with delayed diagnosis and advanced disease. And we also found that they have more often emergency contacts with the healthcare system, again, underlying the hypothesis that there is a problem with understanding the healthcare system and how it works in Denmark. And together with a group of the WHO Europe and an expert group of childhood cancer, but I'm coming to that in a second also later on, we thought about other mechanisms. So this is really hypothesis I'm presenting now and not evidence, but we also thought that probably communication with healthcare professionals might be different for different socioeconomic groups, that families' social resources and coping behavior is different between social groups and might lead to differences in survival. And treatment abandonment probably differs. Another reason could be toxic death. And what also a pediatric oncologist suggested was that parents' attitude and understanding of second-line therapy could play a role. But again, these are all hypotheses and not evidence-based. And for differences between countries, actually, probably limited access to first-line diagnostic and high-quality therapy and supportive therapy are the most important mechanism. That's at least what we think. And that's related then to organization of care probably and infrastructure of the country, including public transport and insufficient financial resources. Yeah, but coming now in turn to what that a childhood cancer diagnosis can also lead to social inequalities of a family, of an affected child, or also after surviving the disease. So I'm starting actually with the socioeconomic consequences during treatment, basically. In a systematic review we have conducted some time ago, we found a high prevalence of different, wide range, different adverse implication on socioeconomic situation of a family and the entire family and the parents. So we found that there was a high prevalence of disruption in parental employment, such as job quitting or job loss, and particularly among mothers. And what we also found that this financial hardship was strongest and most pronounced at the very beginning of the treatment, but lasted really into survivorship, like several years after the child had the cancer diagnosis. And at particular risk we found were families of children with a hematological malignancy, families of children being diagnosed at young age, and parents with lower socioeconomic status. And because I found it so interesting, and Denmark is probably the country with the best welfare, not the best, but one of the most comprehensive welfare systems and one of the most comprehensive family support when a child is having cancer, found it very impressive that when we looked at how the socioeconomic consequences are for parents in such a country, we still saw that here we see the unemployment rate of mothers, which is increasing substantially directly after a childhood cancer diagnosis. So we followed the parents actually here from 0, where the childhood cancer diagnosis was, up to 10 years afterwards. And there was a substantial increase in unemployment rate in mothers of children with cancer, which is not true for most recent period, but for the 80s and 90s it was the case. And here we looked at the income of mothers and the quintiles of incomes of the maternal income, and it really dropped. You can see very nicely here. And so I was very shocked by those results. I mean, on the other hand, it's of course reassuring that you don't see anything in the most recent period, but yeah, still in society you see that. Coming now, what I was mentioning before, to survivorship, it's not only that during the time period of treatment that social inequalities can occur, it's also that there's growing understanding that late effects attributable to childhood cancer or its treatment are not limited to somatic and mental disorders, but that survivors are also facing socioeconomic difficulties in their later life. But the evidence, or the current evidence, is still limited by considerable methodological shortcomings, and we still don't know about the mechanisms that lead to those adverse social and socioeconomic conditions. And that's why the SALiCCS research program was initiated. It's the Nordic population-based register study of childhood cancer survivors from Denmark, Finland, and Sweden. Some of you might know that in the Nordic countries, they have these registries, basically cover all aspects of life, from cancer registries over hospitalization registries, medical birth registry, income registry, education registry, address registries, and those registries are set up from the 60s, 90s, 60s, 70s, 80s, so you can really have a long-term observational studies, and individuals are really followed from cradle to grave. So you have a unique identification number, and then those information can also be linked. So we took advantage of this situation, of the register infrastructure and the high quality of those data, and set up the SALiCCS research program. And in this research program, we have now more than 21,000 5-year childhood cancer survivors, and 5 times as many population comparisons, and we also have information about the parents, and we have a sibling comparison group, and we have all kind of outcome information. And it's still work in progress, but I wanted to show you first key findings because I found them very interesting to make available to the community. So it's work in progress, but what we see here is a graph showing the proportion of survivors in comparison having achieved upper secondary education by the age 19 to 25, what you can see here. Right, and what we can see that by the age 19, 20, 21, there is a huge difference between the population comparison, which should mirror the actual average of having achieved upper secondary education, and here different kinds of childhood cancer survivors. Interestingly, by the age of 24, 25, all childhood cancer survivors, but CNS tumor survivors show the same proportion of secondary education. But the CNS survivors don't catch up, meaning that there is a substantial difference, a substantial risk in CNS survivors not achieving this milestone of education, which is of course having important implication for later life. Here in this figure, you see that it's actually with 2.05, it's a double risk of not achieving secondary education, and also for lymphoblastic leukemia, there's a slightly increased risk. Another first key finding I wanted to show here relates to employment status and in childhood cancer survivors. So we looked at unemployment and specifically also at health-related unemployment. And so survivors were more often health-related unemployed, and about 2.5 times more often, and this persisted even over time, as you can see nicely here. So there is an increased risk. It goes a little bit down, but just a tiny little bit. So even at age of 50 years, there is a double increased risk of being unemployed because of health-related risk. And then we were interested in looking who was most concerned by this pattern. And we do see here that, again, it's CNS survivors having a substantially increased risk, also neuroblastoma, but it actually concerns all kinds of childhood cancer survivors. And again, I was saying before that we were interested in understanding the mechanism behind those socioeconomic adverse outcomes. So this is one pathway we hypothesis. We thought that particular for CNS tumors, those outcomes might be related to cancer treatment, and then maybe somatic-related effects occurring, or directly psychiatric-related effects, or from somatic-related effects to psychiatric-related effects, and then, of course, this causes health-related unemployment in adulthood. Yeah, but this was just a snapshot. It's still work in progress, and we are just publishing the first papers. And so in general, taking all the international evidence into account, we can conclude at the current moment that there's evidence, as I just mentioned for the SALiCCS study, that there's a lower level of attained education, but there's also poor school performance, higher attendance of special education or learning disability programs, lower income level, and greater uptake of social security level, and higher unemployment differs quite a bit between countries. It's actually particularly pronounced in the US. And risk group do not only include survivors of CNS tumors, but also it seems that diagnosis at young age is of importance, and in general treatment with radiation therapy. So to conclude, there is rapidly growing evidence about social inequalities regarding childhood cancer, and most postulated mechanisms and pathways are rather speculative than evidence-based. I found it a very important topic to tackle and to address because I found it so unfair and unnecessary. And I'm not alone, so many national and international foundations, society, including Childhood Cancer International, WHO, and SIOP, are initiating at the moment campaigns and initiatives to raise awareness. So does also WHO Europe. We are just at the moment working on a childhood cancer inequality report. I'm doing this together with, under the leadership of WHO Europe and together with an advisory group, and that comprises all kinds of leaders and societies in childhood cancer research from across the world. The aim with this report is to raise attention of high political level and advocate and inform the cancer community in general on childhood cancer inequalities in countries, but also across countries. Yeah. And we hope to launch the report on the 15th of February, which is the International Childhood Cancer Day, and hope to raise awareness and make a difference in the long run. And yeah, this is the end of my talk, and I'd like to acknowledge all my collaborators and colleagues who have worked with me on these different aspects of social inequalities in childhood cancer, and thank you for your attention.
I would like to thank very much indeed Dr. Friederike Erdmann for her wonderful and excellent presentation that gives a lot of light for the inequalities during therapies, and very important also for the survivors, especially after taking into consideration that one adult out of 500 approximately would be a survivor of childhood cancer. And now it is estimated that there is more than 500,000, 500,000 adults in the European Union that are survivors. So this is very important what you have presented, and we are waiting for the publication and final results. Thank you very much.